First is psychiatric emergencies. So if someone has neuroleptic malignant syndrome, what's the first line treatment? So the first thing is actually discontinue the the psych, and then you administer dantrolene. If they have discontinue as A and B dantrolene, pick discontinue. How do you tell the difference between neuroleptic malignant syndrome and serotonin syndrome? Serotonin syndrome has myoclonus, whereas neuroleptic malignant syndrome doesn't. They have very similar pictures. They'll both be febrile. They will both have rigidity. So you might get confused. But the tiebreaker is that serotonin syndrome has myoclonus. Also, look in the history. It helps a lot. The drugs that they take will help you decide, like, if they have depressive disorder, then it's serotonin syndrome. But if they have schizophrenia, then it's most likely neuroleptic malignant syndrome. So you put the clinical picture, and then if you're still stuck, look at what drugs they were taking before. And then how do you treat that? Benzodiazepines or cyproheptadine. Either one works. Yeah, discontinue should always be the one that goes first. If none of those are there, then obviously pick the drug. What type of antidepressant predisposes to tyramine crisis? Exactly. Can you name an MAOI? Phenelzine is the main one. There's like other ones too, like isocarboxazid and stuff, channelcypramine. If you have a tyramine crisis, how do you treat it? So basically for tyramine crisis, it's just hypertensive emergency. So you want to use the hypertensive emergency drugs. Antipsychotics, you have to know about the extrapyramidal symptoms, the EPS, and there's 4 of them you need to know. First is dystonia, second is akathisia, third is Parkinsonism, and fourth is tardive dyskinesia. And you have to know how to diagnose it and treat it. So the first is dystonia. That happens like right away. It can happen within hours. And this is basically muscle spasms that do not relax. And the high yield part of the body, what part of the body usually spasms? The sternocleidomastoid. So you have some where you'll have like torticollis, your neck will be turned and it'll stay contracted. That's called dystonia. And then what is the treatment for that? So the way I think about it is all the EPS antidotes start with B. If you make diphenhydramine Benadryl, then they all start with B. So acute dystonia is benztropine or Benadryl. So what about akathisia? Akathisia is where they have the restless kind of, they feel like they have to keep moving all over the place. They can't sit still, where they're just constantly restless. What's the antidote for that? They all start with B's. Yeah, benzos or beta blockers. Third one is Parkinsonism. What's the treatment for that? Benztropine. The answer I was looking for is benztropine. The last one was tardive dyskinesia. So tardive dyskinesia is more like chronic, later, like months or years after using it, where you get like the lip smacking, kind of like, think of like the Joker in Dark Knight with like the weird movements. What is the antidote for that? What's the first thing you want to do? What would be the most likely answer? Discontinue. Exactly, discontinue. And then what kind of drug would you want to switch them to? So clozapine is something you can use safely in patients who have tardive dyskinesia because it has the least risk for causing it. But then what is the main side effect of clozapine? So what kind of lab tests do you want to do periodically? Yeah, so if a patient is on clozapine and all of a sudden they have an infection, what should you do? That means that they have agranulocytosis, right? Because they have decreased white blood cells and now they're getting like infections because of it. So you have to discontinue clozapine. And then also one thing to know about clozapine, another special thing, is it's the antipsychotic that decreases suicide risk the most out of all of the antipsychotics. What is a mood stabilizer that is known to lower suicide risk the most? Lithium? Yes, lithium. Lithium toxicity. How do you treat lithium toxicity? Hydrate aggressively with IV fluids and hemodialysis. Because remember, dialysis, there's that mnemonic AEIOU. Acidosis, electrolytes, intoxicants, overload, and uremia. So lithium falls under the intoxicants category. And the intoxicants that you want to dialyze are that there's a submnemonic. It's called MALE, MALE. So that's methanol, aspirin, lithium, and ethylene glycol. TCA toxicity. What's the antidote for TCA toxicity? Yeah, sodium bicarb. Now here, they'll ask you this. A, is it because it alkalinizes the urine? B, alkalinizes the blood? Or C, blocks sodium channels? Don't be fooled by bicarb. It's actually the sodium part that is overturning the TCA, because the TCA blocks sodium channels in the heart. So when you administer sodium, you're flushing out the TCA. It has nothing to do with acid base. What's cocaine overdose treatment? It's benzodiazepines. Yeah, usually IV lorazepam will be first-line treatment, and then you observe them from there. Yeah, you don't want to give beta blockers because that can, in theory, cause unopposed alpha vasoconstriction, which isn't good for the coronary arteries. First-line cocaine overdose is benzodiazepine. What about alcohol withdrawal? Benzodiazepines. Delirium tremens, that happens 2 to 4 days after discontinuing alcohol. Delirium tremens, first line is benzodiazepines as well. How do you know the difference between alcoholic hallucinosis versus delirium tremens? Timing, and also the one thing you want to look for is blood pressure. So alcoholic hallucinosis, their vitals are pretty stable, but with delirium tremens, they usually have unstable vitals. They'll be hypertensive, tachycardic. Yeah, so that's what you'll look at next for the vitals. And also timing. So hallucinosis will be within like 6 to 12 hours, and then delirium tremens is like 2 to 4 days after stopping alcohol. PCP overdose, what's the treatment for that? So a lot of these stimulants, if you're kind of stuck and you have to guess, pick benzodiazepine. So how do you diagnose PCP? It's usually they're violent, right? They're violent, that's the main key. They're psychotic, and when you look at their eyes, what will you see? Nystagmus. Exactly. And also, if you want one more kicker, if you're still not sure, the blood test will show elevated CPK. Just like neuroleptic malignant syndrome. In psychiatry, there's only 2 big associations with CPK, and it's usually PCP and neuroleptic malignant syndrome. If someone has benzo overdose, what's generally the antidote for that? Yeah, flumazenil, but you have to be careful with that, because if it's only really used in people who aren't addicted to benzos, because if they're like addicted to it and take it all the time, when you give them flumazenil, they can get life-threatening withdrawal. Someone takes benzodiazepines a lot, and now they're like withdrawing, so they're like tachycardic, diaphoretic, hypertensive, and they look like they're not well. How do you treat them? Give them benzodiazepines again, you give it back to them, and then you taper slowly. It's weird because you treat it with the actual drug itself. Because the reason why is usually it's precipitated when people discontinue it too suddenly. So you're redoing it. You're like, oh crap, I discontinued it too suddenly. Let's give it to them again. It'll make them feel better. But this time we're not going to make this mistake. We're going to take them down slowly. And then opioid overdose, that one everyone knows, it's naloxone. And then opioid withdrawal, though, not everybody knows this. How do you treat opioid withdrawal? So yeah, this one is the one where it's supportive. So you're going to treat them with clonidine. The uppers are the stimulants like cocaine, PCP, and then the downers are like benzodiazepines, opioids. So the uppers are non-fatal when you go into withdrawal, but the downers can be fatal. And the 2 famous ones that can kill you from withdrawal is alcohol and benzodiazepines. But opioid withdrawal can't kill you. But benzodiazepine can, because you can get status epilepticus and die. And alcohol, you can get really bad seizures too and die. So remember, for antipsychotics, the 4 pathways, you have mesolimbic, mesocortical, substantia nigra, and tuberoinfundibular. So the antipsychotics block dopamine, right? They work on all 4 of these tracks. So remember that mesocortical is responsible for the negative symptoms. Mesolimbic is responsible for the positive symptoms. Tuberoinfundibular, that's the dopamine prolactin pathway. Remember, dopamine blocks the release of prolactin, right? It suppresses prolactin release. So if you give an antipsychotic, you block dopamine. So now that blocking mechanism is removed. So now you have prolactin free to secrete. And then That's what leads to hyperprolactinemia and then gynecomastia. There's an antipsychotic that's famous for doing this side effect. What is it? Perfect. Good job. And then there is your Parkinson substantia nigra, which is, remember, where your dopamine neurons, help control your basal ganglia for your normal movements. So basically, if you block that, then you can have Parkinsonium. So this is also really important too, is knowing good prognosis versus poor prognosis for schizophrenia. I'll say something and then you tell me if it's a good prognosis or bad prognosis, okay? So late onset. So late onset is good prognosis. Early onset is bad prognosis. What about if you're a male? A male usually has a poorer prognosis than a female. What about slow onset? Slow onset is usually a bad prognosis. So just to recap, if someone has acute onset and it happened later in their life and they're a female, those are the best prognostic indicators. If it started in your early 20s and it came on really slowly and you're also a male, that's probably the worst prognosis you can have. So like a late 30s female who became psychotic in a day, that's a good thing. But a dude who slowly got more and more psychotic over 10 years, that's a bad thing. So they'll ask you sometimes like, oh, which of the following is a good prognostic indicator? And then you'll be like late onset. Or it might be like a behavioral question and be like, what would you tell the patient? And then they gave you like all the signs of like poor prognosis. And then the answer will be like, patient has a poor prognosis. Boom, that's the right answer. So that's why you need to know these things. And then, so remember how you have your antipsychotics, right? You have 3 classes. You have your first generation and your second generation. But your first generation goes high potency and low potency. So your high potency ones, you have to know what side effects that are common with the high potency ones. So EPS is common with the high potency ones. And then the low potency ones are what's common for the low potency first generation. Exactly. But I would expand it. Like every time I always, instead of thinking anticholinergic, I just think HAM block. You know what HAM block is? Antihistamine, anti-alpha, anti-muscarinic. So antihistamine, that's not really relevant. It kind of would help you through allergies, but anti-alpha, that can predispose to orthostatic hypotension, right? And anti-muscarinic would cause like, memory problems and also like sleepiness. Actually, histamine can be sedating too. And then you have your second generation ones, which are the ones that are like clozapine, quetiapine, risperidone, olanzapine, aripiprazole, ziprasidone, all those ones. Those ones have famous side effects too. And which ones are they? Metabolic syndrome. So it can cause obesity, it can cause high cholesterol, it can cause diabetes. So with those, you should periodically check what? Their BMI, their blood pressure, their glucose, their lipids. So remember that. But the most famous one for metabolic syndrome is which one? Olanzapine. Yeah, so O should remind you of like obesity. First generation antipsychotics, but thioridazine, what is the adverse effect that it's famous for? Retinal pigmentation. And then chlorpromazine, what's the famous side effect? Corneal deposits, C. So chlorpromazine, corneal. Thioridazine, retinal. So then you have to know about schizoaffective disorder. So schizoaffective is, remember, okay, so people get this one confused a lot with major depression with psychotic features. So the key here is you have to ask yourself, what is baseline? If baseline is schizophrenia, then this is schizoaffective. If baseline is depression, then it's major depression with psychotic features. So schizoaffective is someone who's baseline schizophrenic, but on top of that, they can have depressive episodes or they can have manic episodes. That's where the affective word comes into play. So schizo plus affective. So they can have schizophrenia with depression at the same time or schizophrenia with mania at the same time. So how do you know whether it's schizoaffective or major depressive? In the vignette, they'll say there's periods of time when the patient isn't depressed, isn't manic, but they still hear voices. If you see that, that means they're schizoaffective. But if major depression with psychotic features, once their depressive episode goes away and they feel good, the voices go away. So that's the difference. So you have to, the key is, what are they at baseline? And then you treat schizoaffective with second-gen antipsychotics or mood stabilizers. The mood stabilizers would be like lithium is the main one, but valproate and carbamazepine are also mood stabilizers. And then remember timeline, right? You have brief psychotic disorder, schizophreniform, and schizophrenia. What's the timeline for brief psychotic disorder? So less than 1 month. Schizophreniform is 1 to 6 months, and schizophrenia is 6+ months. And you have to have hallucinations, delusions, and disorganized speech or negative symptoms. So those are kind of like the 4 things you're looking for in schizophrenia. And then depending on the timeline, you give it a different label. There's delusional disorder, which is at least 1 month of delusions. But do they function normally in society or not? Yeah, they do. So delusional disorder, no hallucinations, just a bizarre belief, but you function normally. Best to worst prognosis, just remember the best prognostic ones would be ones that are like mood disorders, and the worst prognosis ones would be like things that are more psychotic. So what would have a better prognosis? Schizoaffective or schizophreniform? Yeah, because schizoaffective has more mood type of stuff, but schizophreniform is like pure psychosis, right? Like what would have a better prognosis, like major depression or schizoaffective?
Depression is
Yes, exactly, because it's more moody than psychotic. So that's kind of how you want to like organize everything in your mind in terms of prognostic indicators. So moody stuff is better than psychotic stuff. Major depressive episode is 5 symptoms for 2 weeks of, you guys already know, Siggy caps, but one of them they always leave out is mood. So I usually just go M Siggy caps to like add it to make it more complete, and you need 5 of those for 2 weeks. And then bipolar, you can use the mnemonic dig fast, distracted, insomnia, grandiosity, flight of ideas, activity, pressured speech, and thoughtlessness. 3 of those qualify for bipolar, but then how do you know the difference between mania and hypomania? So mania requires hospitalization and hypomania does not, but there's also timing too. So you have to know that during mania, they've had to have at least of 3 of dig fast for 1 week, at least 1 week. Whereas hypomania, they can have at least 3 of dig fast for 4 days in a row, but they don't require hospitalization. Tricyclic antidepressants, gotta know about the adverse effects. And they always do like the TCA poisonings. So remember the main side effects are ham blockade and the tri-Cs. So the tri-Cs are cardiac, convulsions, and coma. And then cardiac, what type of cardiac things happen? It's long QT and arrhythmias. A lot of times too in these TCA questions, they'll show you an EKG to show you the long QT. Serotonin syndrome, remember in the vignette, look for someone who was started on an SSRI and then they discontinued it and started a different antidepressant too quickly in a different class. So like they might have had an SSRI, right? Stopped it for like a week and then started an MAOI right away. That is a typical serotonin syndrome vignette, because when you stop SSRIs, it takes about like a few weeks to wash out all the serotonin before starting another one. How long does it take antidepressants to start fully working? Yeah, so you'll get a question where the patient has been taking it for like 2 weeks and they go, hey, it's not working, what should I do? And then what should you say? Continue it for 4 to 6 weeks. And then conversely, what if a patient has been taking an SSRI, it's worked for the last few months, and they want to stop it? What do you tell them? They should take it for at least 6 to 9 months. Okay, so what about this? If they're taking an SSRI and they have side effects, but it's working, yeah, a different SSRI, keep it within the same class. But what if it's not working at all? If it's not working at all, you can switch drug classes. Another thing is electroconvulsive therapy, ECT. This is used for emergencies. So this is used if you need rapid changes. And there's 2 classical scenarios. What are the 2? The patient who will not eat or drink It's been a few days where they're basically going into starvation mode, so that's dangerous. That's one. What's the second one? Second one is the high suicide risk. High suicide risk or refusal to eat or drink. It's the highest efficacy of all the depression treatments. But then you have to remember there's a side effect with ECT. What is it? Yeah, they'll have amnesia for around 6 months, which will resolve. There's a patient who has been taking antipsychotics, and then lately they've been having like these purposeless movements where like you'd move their arm and they would just stay like that. And it could be described as waxy flexibility. What is that called, and what would you treat it with? Catatonia and catalepsy. Catalepsy is a type of catatonia. Yeah. So, and what's the treatment? Yeah. So this one you have to be specific. You can't just be like, oh, it's a benzodiazepine, because sometimes there's questions where they'll have 2 benzodiazepines in the answers. So this one you have to be specific. It's lorazepam. The main thing that distinguishes peripartum blues from peripartum depression is, remember that the key thing is that in depression, the mom has an inability to enjoy their child. Whereas peripartum blues, it's more like mild, like they have like, they're like tearful and sad, but they can, still enjoy their kid. But someone who's depressed, the sign is that they've lost interest in their child. They like to test you on this too. Do you know the difference between grief, like normal grief, versus major depressive disorder? So the key thing here that I've noticed in questions because a lot of times it can be very similar and you'll be like torn. You're like, I don't know, is this normal grief or is this depression, right? But the main thing is that the person who's grieving, like bereavement, they have good days and bad days. They have ups and downs, but the person who's depressed is down all the time. So in the vignette, they'll be like, oh, this patient, has moments where they like to go outside and look at the ocean and enjoy for a bit, but then they're back to being sad. Like that's grief. And also on top of that, depression will have feelings such as like worthlessness. How about this? If the patient had someone who recently died in their life, right? Say they're like an 80-year-old lady who's been married for like 60 years. Her husband just died a few weeks ago, and she says she wished that it was her that died instead. And she's been seeing him recently in the hallways. Is that normal or abnormal? That's normal. So it's normal to like see like people that have died. It's quite common. And also it's normal to have these feelings of guilt where you wish you died instead. But that's why it's sometimes very hard to make the call whether it's grief or depression. So those things will really confuse you. So remember, I'm telling you, every time it's a grief vignette, then there will be ups and downs. Do you guys know about the lithium LMNOP mnemonic? Lithium causes movement disorders, nephrogenic diabetes insipidus, hypothyroidism, and pregnancy problems. It's a cardiac problem. What is that problem? Yeah, what is it? Can you describe it anatomically? Exactly. Yep, good job. All right, so persistent depressive disorder is also known as what? So how long does a person have to be suffering for you to make the diagnosis? Yes, 2 years. And remember, it can be 2 years of major depressive disorder, right? That's 5 of, but it can also be 2 years of not quite depression. So they might have only 2, not quite meet the criteria for depression, but it still counts as persistent depressive disorder. And then cyclothymic disorder, I kind of think of it as like bipolar type 3. It's like not quite bipolar. It's very mild, and like when you are manic, it's not quite hypomania, and when you're down, it's not quite depression. And this has to last for 2 years. So cyclothymia is like not quite depression, not quite hypomania, and for 2 years. The next one is premenstrual dysphoric disorder, which is the medical word for like PMS. And then what's the answer when the person comes in initially to the clinic with these complaints? And what is the first thing that you should tell them to do? Yeah, keep a menstrual diary. That's usually the answer. And then say they keep a menstrual diary, and then you read it and you're like, okay, yeah, this is definitely PMDD. What's the first line treatment? No, so that's different. That's for dysmenorrhea. Dysmenorrhea is different than PMS. So dysmenorrhea is when you have painful periods, right? And the first line treatment is NSAIDs, right? Because remember that dysmenorrhea is actually attributed to uterine contraction, which is prostaglandin mediated. So NSAIDs block the prostaglandin, so you don't get the uterine contractions. But this is premenstrual dysphoric disorder, which is a mood thing. You get like mood swings. SSRI. First line is SSRI. So don't mix that up between that and dysmenorrhea. First line for dysmenorrhea is NSAIDs, but first line for premenstrual dysphoric disorder is SSRI. So someone comes in with an acute panic attack. What are you going to give them? Benzo. Acute panic attack is benzo. But how do you treat panic disorder? Yeah, so panic disorder is treated with SSRI, but an acute panic attack is treated with the benzo, because the benzo is more fast acting, remember? But SSRI takes like 4 to 6 weeks to work. So here's another thing that people always fall for the trap, is they can't distinguish between a panic attack versus pheochromocytoma. So how do you tell the difference between the two? The blood pressure is key. Someone who has pheochromocytoma will have hypertension. And then remember though, to diagnose a panic disorder, it's someone who has to have at least 1 month of fear of getting another attack. And another key thing is that these attacks come out of the blue. So another thing that you can confuse panic disorder with is a phobia, because phobias can precipitate panic attacks, but with a phobia, the stimulus is what triggers it. So every time they see a snake, they get a panic attack. That's not a panic disorder. That's a specific phobia. A panic disorder comes out of the blue. There's no trigger really. So that's how you kind of distinguish from the different ones. Public speaking phobia, what's the treatment? Beta blocker. When would you, instead of giving a beta blocker, when would you give a benzo instead? You'd rather give a beta blocker because a benzo kind of makes you act kind of drunk, because it's like sedating a little bit. But the only time you would give a benzo is if the patient who has a public speaking phobia also has asthma. Because if they have asthma, you can't give a beta blocker. It's contraindicated. And there are questions that will have a public speaking phobia patient, and A will be beta blocker and B will be benzodiazepine, and then you look and then they have a past medical history of asthma, and then you'll quickly click beta blocker and it's wrong. It's benzodiazepine. So make sure you check for asthma. Social anxiety disorder versus avoidant personality disorder. These are two that people get confused a lot too. Social anxiety disorder is fear of embarrassment in public. They don't like to go out in public, restaurants, do public speaking or restrooms because they don't want to get embarrassed. Whereas avoidant personality disorder, they have fears of getting rejected, or they feel like they're not good enough for people. But the thing is, these people want to make friends, but they don't know how to make friends. So sometimes those ones can overlap too. Social anxiety disorder versus avoidant personality disorder, because they both don't really like to go out. But the avoidant person secretly wants to, but they just don't think they're cool enough. But social anxiety disorder person, it's actually they don't want to get embarrassed in public. And the key thing here too is that social anxiety disorder, it revolves around public areas, whereas avoidant personality disorder, it can happen anywhere. It can be just hanging out in a private area too. They don't really want to do it because don't want to get rejected. And then the first line for those ones is CBT. OCD, what's the first line treatment for that? This is one of them where you can't just say, oh, cognitive behavioral therapy. You have to be more specific with it. It's called exposure response control. Okay, this is another high yield one. Someone who has borderline personality disorder, what's the type of cognitive behavioral therapy for that? Dialectical behavioral training. Just remember the word dialectical. That's actually, no, I'm not even joking. That is super high yield. How you diagnose borderline personality disorder is, remember, their mood switches really quickly. It can switch on a dime. And they use a defense mechanism called splitting. And they also use extremes of language. This person's terrible. This person's amazing. They use very extreme words. And also they have history of suicidal behavior. Yeah, self-harm, splitting, very rapid changes in mood, and extreme uses of language. No in between. Everyone's either terrible or amazing. Adjustment disorder, this one's kind of tricky too, but it doesn't quite meet depression criteria. So if you don't quite count 5 of the 9 and then look in the vignette, it shows that there was some sort of life event that happened less than 3 months ago. This is adjustment disorder, and the treatment is just supportive. At what age does conduct disorder become antisocial disorder?
18.
Yeah. What's the difference between conduct disorder and oppositional defiant disorder? Who is the one who breaks laws?
Conduct.
Yeah, so that's the difference. Both can have like attitude problems, right? But the conduct person doesn't care about rules or laws. So if someone's just like fighting, burning things, stealing, that's conduct. Oppositional defiant is more kind of like a rebellious type of attitude, but they don't really break laws. Okay, what's the difference between OCD and OCPD? The difference is that OCD is something called ego dystonic, whereas OCPD is ego syntonic. So the person with OCD hates that they have it. Like they have these intrusive thoughts and they have to like wash their hands all the time, and it's really bothering them. Whereas the OCPD, obsessive compulsive personality disorder, they are like a perfectionist, but they enjoy it. Yeah, it's a part of their personality and it doesn't bother them. But the OCD person, it bothers them. What kind of medications would you give to treat someone with alcohol use disorder? There's 2. Naltrexone is 1. What's the second one? I can't proceed. Disulfiram. What's the mechanism of action of disulfiram? It's an acetaldehyde dehydrogenase inhibitor. So it increases acetaldehyde, which induces nausea and vomiting. So it's very unpleasant. But you don't really give that anymore because it's kind of just, people will just not take it just to drink. Exactly. If someone is taking hallucinogens and they're intoxicated with it and they're freaking out, how do you treat them? Enzo. Okay, how about this? This kid, he is in high school and he has like a perioral rash and he's been acting like psychotic for the last hour. And then you observe him in the ED and after an hour, he goes back to normal. What substance did he most likely take? Inhalants. The perioral dermatitis is called a glue sniffer's rash. And so that's the key with the dermatitis around the mouth. And also the psychotic symptoms go up and down very quickly because there's like a very quick half-life. All right, what about nicotine addiction treatment? What drug could you use? This one is a partial nicotinic acetylcholine receptor agonist. Varenicline. Another one is contraindicated in patients who have seizures and who have eating disorders. Bupropion, because bupropion lowers the seizure threshold. So those are 2 drugs that can be used for nicotine addiction. But what's the actual first line? Patch and gum. If someone has delirium, what would you see on EEG? Diffuse background swelling. What is like the number 1 kind of vignette for a patient who has delirium? Like what type of demographic? An old person who's on lots of meds, or like, yeah, UTI. What 3 medications are most common for causing delirium? Benzodiazepine is 1. Second is anticholinergic 2. So they won't just say that, right? It'll probably be a patient taking like Benadryl all the time. TCA. So those are the 3 meds. And then if you see them on it, usually the correct answer is to discontinue that drug. But then remember that infections can also cause delirium. So that's why you would do like urinalysis, right? Check blood culture, lumbar puncture, those types of things too, and find the source of the infection if they're not taking any of those drugs. If someone seems to be delirious, but they have dilated pupils and they're tachycardic, what should you do next? And it's like a younger person. You're in toxicology. So people who are intoxicated with drugs can be delirious too. If someone has a neurocognitive disorder, remember you have to first rule out the reversible causes. So B12 deficiency, thyroid, syphilis, these are types of things you want to rule out. Normal pressure hydrocephalus. And then remember, normal pressure hydrocephalus is wacky, wobbly, wet. What's the first line treatment of normal pressure hydrocephalus? That reduces CSF pressure, but what's the definitive treatment? Ventriculoperitoneal shunt. What if you have an obese girl who's taking Her BMI is like 35. She's 25 years old, and she takes isotretinoin orally, and lately she's been having headaches. On fundoscopy, you notice papilledema. What's the diagnosis? Yes, pseudotumor cerebri, which is associated with vitamin A use and obesity in a young female. But remember that you want to do a CT of the head first because they have papilledema, and you do a CT of the head, and then you see like, enlarged ventricles, then you do the lumbar tap to reduce the pressure. Key thing for Alzheimer's in vignettes is when they get lost on the way home. So if someone gets lost on the way home and it's been like over a year of like memory loss, that's most likely Alzheimer's. And it's a clinical diagnosis. Okay, true or false? Antipsychotics increase mortality in patients with dementia. It's true. If you had to give antipsychotics to an elderly, like someone who's really agitated and psychotic, and you need to like treat it right away, what would you give them? So the two antipsychotics that you can give to the elderly that are safest are olanzapine and quetiapine. Vascular dementia is something else too, and the key here is stepwise decline. So they just keep getting like multiple vascular infarcts, and it's stepwise decline. And then the key is to look for risk factors. They'll probably have like hyperlipidemia, hypertension, diabetes, all that. What's the mechanism of action for drugs that you use to treat Alzheimer's? Exactly. What does that do? Yes, exactly. So name some medications that you can use? Galantamine, rivastigmine, donepezil, and then it's grandma doesn't remember, right? Galantamine, donepezil, rivastigmine. What about, I say, old man who's recently having personality changes, inappropriate behavior, and memory loss? Frontotemporal dementia or Pick's disease. Okay, what about Huntington disease? What's the mode of inheritance? Yeah, so what's the repeat? What's the inheritance? So if it's autosomal dominant, the giveaway is that the patient's parent, one of them had it and died in their 40s. Yeah, and this is the one you have cognitive decline with chorea, where you're like dancing like uncontrolled movements. How do you treat Huntington's disease? Tetrabenazine. If I say startle myoclonus, rapid progression within months, what's the disease? Prion disease, also known as? Yes, good job. On pathology, you would see this. It's blank cortex. Yeah, good job. Spongiform cortex. On EEG, you would see sharp wave triphasic complexes. True or false? True. That's one of the EEG findings you have to find. Another one is an absence seizure. What would you see on EEG? 3 Hz spike. So prion disease has the triphasic sharp wave complexes, but absence seizures have the 3 Hz spikes. So they both have like tri. But in an absence seizure, people tend to confuse this with a complex partial seizure. So because they both happen in young kids, and both of these young kids will have like signs of like zoning out or like lip smacking type of things. How do you tell the difference between the two? So the key thing here is a post-ictal period. If you have a kid that is zoning out in school with the lip smacking, but afterwards he's not confused at all and goes back to normal, that's an absence seizure. But if afterwards he's confused, that's a complex partial seizure. How do you treat absence seizures? Yep, good job. True or false? If someone had a MI in the past or a stroke and they're depressed, are they more likely to die? Yeah, they're 3 times more likely to die. And a question might be like a behavioral question, and the person has like depression and they don't want to get it treated, and they just had an MI a few months ago, and the answer would be something like, oh, you're at increased for mortality if you don't treat your depression. Oh, restless leg syndrome. So this is the person who lays in bed. They have like feelings of restlessness in their legs. It's very uncomfortable. It can be distressing. What do you treat it with? Dopamine agonist. What is it associated with? It's associated with iron deficiency anemia. So restless leg syndrome can present similarly to akathisia, and akathisia is one of the side effects of antipsychotic. So how you tell the difference is that in akathisia, the patient has been taking antipsychotics. But restless leg syndrome, they haven't been taking it. Teeth grinding, what stage of sleep? At what stage? N1, N2, N3, N4, REM? Like what? N2. What about night terrors? N3. If there's an elderly person with multiple bruises of different stages, what should you do next? The caretaker is in the room with the patient. Talk to the patient by themselves. Now that you've talked to them by themselves and you suspect abuse, in cases with elderly patient abuse, who is the prime suspect? The caregiver. With little kids, if you suspect abuse, the first thing you want to do before you call Child Protective Services, before you do like a bone survey and everything, is you separate them from their parents. You admit them to the hospital. If admitting to the hospital is not in the answer choices, then yeah, pick Child Protective Services. Tourette syndrome, how long do you have to have symptoms for? Because there's something before that. It's called provisional tic disorder. That's less than a year. But something greater than a year gets called Tourette syndrome. So it has to be 1 year. And then remember, Tourette's is a combination of motor tics and vocal tics. Whereas if you have only one, then that's what you call a vocal tic disorder or a motor tic disorder. But Tourette's is both, and it has to be there for a year. And you need motor and vocal. So example of motor would be blinking, shrugging. Example of vocal would be like coprolalia, echolalia. First line treatment in Tourette syndrome is what? Habit reversal therapy. Second line is medications. What are the medications you give? Atypical antipsychotics, so second gen. Guanfacine or clonidine is also possible. Obviously, they won't give you the competing choices that will all work, so you just kind of memorize the possibilities, and then in the answer key, they'll just show one of them. Enuresis versus encopresis. At what age do you diagnose encopresis? Like at what age where they're not poop potty trained is it considered encopresis? 4. It's 4. So the way I remember this is 4. 4 is poop. P-O-O-P. And then enuresis is untrained urination. At what age is it not normal? That's 5 years old. So the way I remember this is urine is 5 letters. Urine. U-R-I-N-E. 5 years old. Poop and urine. What is first line treatment for urine alarm? What's second line treatment? It's an ADH receptor agonist. Good job. Side, can you name me an ADH receptor antagonist? Demeclocycline is an ADH receptor antagonist. But there's another one though too, is conivaptan and tolvaptan. Yeah, you can use it in SIADH. However, what's first line treatment for SIADH? Fluid restriction. In order to diagnose someone with ADHD, at what age of onset did it have to start at? Before 12. So somatic symptom disorder is, remember, this person has pain in multiple organ systems. Could be GI, nervous, could be musculoskeletal, like a laundry list of complaints, but there is, and you do an extensive workup and you can't find a diagnosis. So it's unexplained medically. What is the treatment? Regular appointments to the doctor. Don't confuse this with generalized anxiety disorder, which they like to trap you with as well. Generalized anxiety disorder can also have symptoms of somatic symptom disorder. Someone who's generally anxious will have a lot of multiple body complaints, but the person who has generalized anxiety disorder is anxious about everything in their life. In the vignette, they'll talk about work, their family, social things, and their own body. Whereas a person who has somatic symptom disorder, all they care about is their body. Illness anxiety disorder, the difference between illness anxiety disorder and somatic symptom disorder is that in somatic symptom disorder, this person is in actual pain. Whereas in illness anxiety disorder, they don't have pain, but they're worried all the time about getting a disease. So somatic symptom disorder, it's unexplained, but they definitely are in pain. Illness anxiety disorder, they're always just like worried, like, oh, do I have this? Do I have that? But they don't have any complaints of pain and they don't have any symptoms. The treatment for that is the same though, regular visits to the family doctor. Factitious disorder, this person is faking sick to get attention. Whereas malingering, this person's faking sick for personal gain. Whether it's to gain wealth, take time off work, a lawsuit, there's some sort of motive. Factitious disorder, it's more just like a psychological thing and they just like people taking care of them. Bulimia versus anorexia, these can overlap a lot too, but there's one tiebreaker that ends it all. What is it? BMI. An anorexic patient has a low BMI, whereas a bulimic patient has normal BMI. Anorexia is an unhealthy caloric deficit. Bulimia, they can both have like binging, purging, eating type of things or like restrictions, but the BMI is the difference. Remember that anorexia though, there's some medical things that you have to know more about than bulimia. For example, anorexics, everything is down. So bradycardia, low BMI, anemia, leukopenia, low electrolytes. You have to know when to admit someone with anorexia to the hospital. One is if they have unstable vitals, so they're like hypotensive. And the second is if they have electrolyte disturbances, like dangerously low potassium. Those are factors you admit them for. And then remember that anorexia is associated with osteoporosis, stress fractures, and amenorrhea. And that's because when you have very low BMI, your pituitary gland stops making LH-FSH, so that's called hypogonadotropic hypogonadism. So low from the brain leading to low estrogen progesterone in the ovaries leading to amenorrhea. And then osteoporosis is also caused by low estrogen levels. So low estrogen levels increases like osteoclastic activity. If say you admit this anorexic patient to the hospital and you start feeding them, and then all of a sudden 30 minutes later they start getting like arrhythmias, respiratory failure, and seizures, what caused that? Refeeding syndrome, which is a deficiency in which electrolyte? It's phosphorus. Refeeding syndrome, you should always be worried about people who are anorexic or like alcoholics who are malnourished. If you feed them too suddenly, you have a sudden drop in phosphorus, which can cause them to get seizures. The mechanism for hypophosphatemia is due to all your cells are so hungry for glucose that they absorb glucose so quickly and they start to enter glycolysis very quickly. And remember hexokinase, that's the first enzyme in glycolysis. It adds a phosphate to glucose. So when hexokinase activity is like at an all-time high, then all your body's stores of phosphorus are depleted instantly. So that's refeeding syndrome, and that's associated with anorexia. But then bulimia has a normal BMI. And that's the one where they have like the calluses on the back of their hand, Russell's line. And then the last one is binge eating disorder, which is where they have a high BMI, which is a BMI of 30 plus, so they're obese. And this is the one where they eat too much till it hurts, and like even when they're not hungry, and they're like embarrassed about it. And then they like usually they eat in private. So that's called binge eating disorder. So you have the three different BMIs: high, medium, low, anorexia, bulimia, and then binge eating. What is the first line treatment for obesity weight loss? Lifestyle modification. Second line treatment is what? Orlistat. Orlistat is a pancreatic lipase inhibitor, but it causes really greasy, bulky stools. Also predisposes to what for vitamin deficiencies?
Oh, ADPK.
Yeah, exactly. When do you do bariatric surgery? If BMI is greater than 40 or greater than 35 with comorbidities. Okay, so you have this patient who is like a 20-year-old dude. He's been like really sleepy during the day lately, even though he gets a good sleep. And then sometimes when someone tells a really funny joke, he'll all of a sudden just collapse. So what's the first line treatment for narcolepsy? Modafinil. What's the mechanism of action of modafinil? It's a orexin agonist. Orexin is the wakefulness hormone, so you try and increase that in the brain. Orexin is also known as hypocretin. When I was saying that sudden collapse of muscle tone with strong emotion, what's that word called? Cataplexy, which shouldn't be confused with catalepsy. What's the hallucinations when they go to sleep called? Hypnogogic hallucination. What's it called when they wake up? Hypnopompic. So someone has nightmares, but they wake up and they don't remember any of it, but their whole family saw that they had like these crazy nightmares. What's that called? That's called the sleep terror. Yeah. What stage of sleep does that occur? Deep sleep, N3. What do you tell the patient's family? Yeah, reassure, perfect. Nightmare disorder though, they can easily remember all the details of their nightmare. What stage does that occur at? Perfect. What is it associated with?
PTSD.
Yeah, associated with PTSD. If someone has PTSD and nightmares, what's the treatment? Prazosin. What is the mechanism of action of prazosin? It's an alpha-1 antagonist. What can an alpha-1 antagonist also be used for? It's used in old men.
BPH.
Yes. Benign prostatic hyperplasia. But what should you be concerned about when you use the alpha-1 blocker? What side effect?
Prostatic hypertension.
Yeah, good job. Okay, so if someone has erectile disorder, what should you rule out first? Yeah, you should rule out if it's psychological. What type of question could you ask them? At nighttime when you're sleeping, do you get them for no reason? Like nocturnal erections and stuff? That means that it's not a physiologic problem, it's a psychological problem. But if they don't get any erections at all, even in the night or like in the morning, then this is more physiologic. The most common cause is atherosclerosis. If they have atherosclerotic causes of erectile dysfunction, what kind of medicine would you give? Yeah, sildenafil. And what's the mechanism of action? PDE5 inhibitor. You have to know the difference between vaginismus versus vulvodynia. So vaginismus is when the person has dyspareunia, but it's pain upon superficial entry of the vagina. That is like when it's the spreading of the vaginal walls that causes a lot of pain. That is called vaginismus. Whereas vulvodynia keyword is in the name, vulva. So they have a very sensitive vulva, allodynia. So it's very sensitive to touch there. So vaginismus is at the introitus, whereas vulvodynia occurs at the vulva. With vaginismus, the treatment is relaxation and like physiotherapy, whereas vulvodynia is also like physiotherapy too. Okay, last stretch. The last chapter is just pure form, and then we're done. All right, so what's the first line treatment for fibromyalgia? Yeah, SNRIs. What's the mechanism of action of venlafaxine? Yeah. So fibromyalgia, remember they have the trigger points and it's associated with stress. Trazodone, remember it can be used for major depressive patients with insomnia because it makes you sleepy, and then yeah, it can cause priapism. Mirtazapine is another one that you can use where it's for people who are depressed who have problems sleeping and poor appetite, because it increases appetite and increases sleep. Both trazodone and mirtazapine can be used safely in the elderly. What type of drug medication should you be careful with using in people who have acute angle glaucoma? So basically, when you have acute angle glaucoma, the person has dilated pupils and that blocks drainage of aqueous humor into the trabecular meshwork. So what you want to do is treat that by promoting meiosis, which makes the pupil diameter smaller, so it stretches out the iris more and opens up that angle. So if you give an anti-muscarinic drug, remember muscarinic drugs cause meiosis, that helps alleviate acute angle glaucoma. But if you give an anti-muscarinic, now their pupils will blow up and that'll plug up the trabecular meshwork. So that's contraindicated. If someone was taking antipsychotics, it works really well, but they're non-compliant with it, what should you give them? You want to give them a long-acting antipsychotic, the ones that last for months. So the word is decanoate. Yeah, those are the long-actings. Remember, people who are alcoholics, chronic alcoholics, are predisposed to Wernicke-Korsakoff syndrome. That's vitamin B1 deficiency. They have confusion, ataxia, nystagmus. And then you want to treat that with intravenous B1 plus glucose, but you give the glucose after the B1, and then you also want to give them folate because they get folate deficiency too. How do you diagnose folate deficiency? Macrocytic anemia, RBCs 100 plus. How do you tell the difference between B9 and B12 deficiency? They both have megaloblastic anemia. So the neutrophils will have hyperlobules, more than the typical 3 to 5, plus macrocytosis. But there's a blood marker that you can measure to tell if it's B12 versus B9. And the B12 will have increased this. What is it? Methylmalonic acid, exactly. B12 has increased methylmalonic acid, B9 does not. On top of it, B12 has neurologic symptoms, which is called subacute combined degeneration, which affects your dorsal column and your corticospinal tracts, whereas B9 does not. Okay, rapid review, okay? Akathisia, first line, beta blocker. Restless leg syndrome, first line, dopamine agonist, ropinirole, pramipexole. Clozapine, main side effect. True or false? It reduces the risk of suicide. True. Risperidone, main side effect.
Prolactin.
Yep. Olanzapine, main side effect.
Metabolic syndrome.
Only mood stabilizer to decrease suicide. Cool. How do you treat lithium overdose? Name me the most common mood stabilizer. Yeah. Okay, what's the heart anomaly that's associated with lithium? If you want to quit smoking, I can give a patch, I can give a gum, but also what meds can I give? Yeah, varenicline's one. What's the other one? Bupropion. Bupropion is contraindicated in what? In seizures, in alcoholics, and people with eating disorders. Why? Because it lowers seizure threshold, and those people are already predisposed to seizures. If you want to quit drinking, what medications can I give? Acamprosate's one. The next one is what? Naltrexone, mechanism of action is what? Mu opioid antagonist. If I say I have alternating constipation and diarrhea, my constipation is relieved after defecation, what's my diagnosis? What's the first line treatment? First, you can try supportive therapy, but then what is a psych med you can give? SSRI. Premenstrual dysphoric disorder, first line treatment. But dysmenorrhea, what's first line treatment? Good. What is the mechanism of action of varenicline? Perfect. First gen high potency antipsychotics, main side effects are what? And so what do you treat? Dystonia. What about akathisia? What about Parkinsonism? First gen, low potency, main side effect is what? Second generation adverse effects are what? Generally, all second gen antipsychotics will have metabolic syndrome, but if you want to get specific, risperidone on top of that will have hyperprolactinemia. Olanzapine is very famous for metabolic syndrome. What type of drugs precipitate to lithium toxicity? Best way to check for TCA overdose is on EKG. You'll see long QT. You'll treat that with sodium bicarb. Benzo versus alcohol intoxication. Alcohol intoxication has nystagmus. Benzos do not. Contraindication to public speaking, giving someone a beta blocker is schizophrenia prevalence is around 1%, depression is around 10%, and lastly, for a kid, when do they know that death is a permanent thing? At 7 years old. If a kid had a puppy that died and they're 5 years old and they're not sad about it, and the parents are like wondering what to do, just reassure them that it's normal for that kid, they're too young to understand.